It's March, which means it's Colon Cancer Awareness Month, the one time of year we can legally talk about your backside for 35 minutes straight. On this episode of the JAFERD cast, I'm joined by GI specialist Dr. Hannah Doe to talk about why the screening age dropped to 45, why your daily salad is a fiber failure, and why your charcuterie board is essentially a carcinogen platter. Don't at me on that one, folks. We're covering the gold standard of naps and why you shouldn't let the fear of the prep stop you from preventing a literal killer. I'm Dr. Mark Papadakis, nobody particularly special, just another freaking ER doctor. Stay tuned, because if you've ever wanted to hear two doctors talk about big fluffy poops with professional sincerity, you're in the right place. All right, I'm here with Dr. Hannah Doe. Hannah, thanks for joining me. Welcome to the show.
Yeah, well, thank you so much, Mark, for having me. It's a real honor and a pleasure to be here with you all on this, fine afternoon.
Dr. Doe and I are actually colleagues on the Bucks County Medical Society, and Dr. Doe is a GI physician associated with Penn Medicine at Doylestown Health. So, Hannah, do you want to talk a bit about yourself, like medical school, where you went to residency, all that kind of stuff?
Yeah, of course. So, I grew up in our state capital in Harrisburg, Pennsylvania, and I went to school here in Philadelphia. I was at Jefferson Medical College, which is now the Sidney Kimmel College.
Wait, is it really? I didn't know that. That's
Yeah,
news to
they
me.
did. Yeah, it's officially renamed. I think it was $100 million
Oh
donation.
my.
Kimmel.
Okay.
Yeah, and then I went on to do my internal medicine residency up in Yale, New Haven. And then I wanted to look for some warmer weather, and I was out in Southern California, and University of Southern California for my GI fellowship. But happy to be back in Pennsylvania. I've been at Penn Medicine Doylestown Health for about 8 years now. As I met you through the Bucks County Medical Society, being a former president, but I'm also really passionate about advocacy, and I'm the medical service line director at my hospital and serve on the med exec committee as well. So again,
Very nice.
to be here and to talk about colon cancer awareness in March, which is just such a, dear issue to my heart. And it's something, I'm happy to talk to your viewers about as well.
Yeah, colon cancer is one of those diseases that has been in the news a lot over the past even couple of years. There's articles and articles coming about this diagnosis occurring in younger people, and we're seeing that in our practice too. But people are also rightfully scared. It's like, oh my God, what's going on? Why is this happening? And I get different opinions all the time. Some people say, oh, it's just the processed foods. Other people say, oh, it's just genetics. Some people say it actually hasn't really changed. We're just being more and more aware of it, or better testing, or, whatever the case is. But, March is Colon Cancer Awareness Month, hence our discussion. And the next episode I'm going to try and push out. FYI, you might get 2 episodes in 2 weeks for the first time in history here.
Working overtime here.
Working overtime depends on how busy I decide to make my weekend. We'll see. We're recording on a Friday. I'm hoping to push this episode out next Wednesday. So yeah. So talk to us. So you've been in obviously practice for a number of years now. Doylestown Health for 8 years. You've done a number of colonoscopy screenings, diagnoses, things like that. Let's talk first about risk factors. So when it comes to colon cancer, what has been the number one highest risk factor for colon cancer?
Yeah, well, I think a lot of things are multifactorial, but definitely family history. So generally, if you have a first degree relative, so that means mom, dad, brothers, or sisters, that can increase your risk. Aging, there is an increased incidence that we're seeing in younger folks, but the older the longer we live, there is just more exposure. And there has been a correlation, increased risk of growing polyps and then developing into colon cancer. I would say the third big risk factor that I see in a lot of folks would be inflammatory bowel disease. So conditions like ulcerative colitis and Crohn's that cause chronic irritation or inflammation to the gut that, if uncontrolled, will definitely increase the risk of colon cancer. And then the last would be, things that people are ingesting. So, high alcohol intake or tobacco. For
How
sure.
about highly processed sugary drinks?
Yeah, so generally what we think is protective against polyps and colon cancer would be high fiber fruits and vegetables and unprocessed foods. So I definitely would agree that if somebody is eating a lot of, we describe things that are highly carcinogenic as in the burnt parts of barbecue. So, if you're
Uh-huh.
and that dark, delicious, crispy part, it does increase your risk of colon polyps as well as highly saturated and processed foods.
It's interesting. Is there any data, and I don't know the answer to this if you know it, about people who live in like southern states with a huge barbecue culture? Like you would talk about Texas barbecue, things like that. Is there a higher incidence of something like a colon cancer or diseases from smoked meats and barbecue and things like that?
That's fascinating. I don't know off the top of my head, the distribution within the United States of the incidence of colon cancer, but definitely do know that the World Health Organization has designated highly processed and smoked foods, like, all the lovely things that we enjoy in a charcuterie board, those things to be a carcinogen, a type 1 carcinogen. So I would imagine that there is a correlation there for sure.
So remember that the next time you host a party with your charcuterie board, people. But it's also important to know that moderation is obviously key. So when we talk about, obviously not everybody drinking alcohol or eating smoked meat is going to develop colon cancer, but it's important to talk about risk and the idea that everything that we put into our body has consequences to some degree. You can eat an all vegan diet and you can still be at risk for heart attack if the genetics are there. It is what it is. What about the age of screening? So it used to be the guidelines were, all right, 50 years old, you got to get your first colonoscopy. Now there's talk about dropping it to 45 if it hasn't been dropped already. I don't know.
It already is, Mark. So that's the really exciting part. So, I think for many, many years, the screening was traditionally at the age of 50. It's that birthday gift at that turn of
Yep.
the century. Generally, there was a carve out. So those with African American ancestry, it was 45. And that was a thinking that due to the underserved nature of the population and or maybe the diet to screen at 45. However, the American Cancer Society several years ago decreased the screening recommendation to 45. And ever since then, all of the subsequent societies, the American Gastro Association, as well as the United States Preventive Task Force, have all lowered it to 45. And in general, we're seeing all insurers, Medicare as well as commercial insurers, really respecting that guideline. And I think that is important because the new data just came out recently that pretty much all cancer deaths under the age of 50 have declined, with the exception of colon cancer. So that is really where we want to make that dent by starting to screen at 45. Because in my mind, Mark, essentially colon cancer is preventable, right? Because we know it starts as a polyp. So I get in there and I remove a polyp that basically allows that person to live longer, and it shows a mortality improvement, which not many studies can show. So it's
Right.
very impressive.
Yeah, and I remember my father started getting screened at 45 because his mother, my grandmother, had colon cancer. So that automatically was, all right, first degree relative, now you're down to a degree. If you have a first degree relative now, does that screening age get lowered to now 40? Or is it still at 45?
It's generally at 45 or 10 years younger than the time of diagnosis of your index family member.
So, yeah, and my father had polyps removed, things like that. My mother has had polyps removed. The scary part about my family history is my mother is adopted. So there's like a whole genetic tree that's missing as far as what am I at risk for, what's she at risk for. Does the task force talk about unknown family history? Do they talk about, oh, now you're at higher risk because we don't know your family history for that reason?
So, unfortunately, we really don't have a lot of data in that sense, but I would definitely say nowadays the genetic testing is so good, meaning there is an in vitro assay of 86 different genes, either a blood draw or a mouth swab, and insurance companies have started covering more, as well as the cost to the patient if they don't meet all the criteria, meaning a degree relative with a proven germline mutation, et cetera, can actually have genetic testing. And I think that's really powerful because most folks may not realize that, I actually have a cohort of patients here in Bucks County that have Lynch syndrome. And it is not actually uncommon that one of their parent or they have been adopted because with Lynch syndrome, it is not uncommon to develop colon cancer in your 20s or 30s. So there can be medical things that may lend somebody to being adopted. So for a lot of these folks, meeting with a good genetics counselor, running a a family tree to the extent that is aware. There's awareness to it. And some folks, even adopted, may have data with their biological parent, that's, in an open adoption. But if not, running a genetic test is a good idea, I think.
Yeah, I agree. I know for people who are suffering for infertility, for example, they go to like fertility specialists, they do genetic testing largely to screen for, inherited disease for that would affect fetal viability, but they also screen for other genetic markers too. I mean, Huntington's, Parkinson's, all of these different things. And I think
100%.
I remember back in the day there was this long discussion about who should get genetic testing. Should it be given to everybody? Should there be counseling with it? Like, should this be kind of like you do it yourself? Is there a referral? Because there's a lot of data that comes with this type of testing, and broad data by itself without any kind of explanation, without kind of analysis, can be very concerning, very dangerous, very gut wrenching for a lot of people too. If you see and say, hey, there's a gene that's for like Huntington's, it's like, oh my god, now what? It's like, well, that's why we need genetic counseling to go along with this here.
100%. They cannot be done apart. And that's why I really, when folks come to me and say that they've maybe done 23andMe or some of those ancestry, commercial products, it's not really quite as good as, sitting down with a genetics counselor, having a referral from a physician, and then having that interpreted. So there are quite a lot of mutations that I may get. So number one, I'm the number one referral to my genetics counselor here at Doyle.
Excellent.
And so, I come across a lot of mutations that may pop up, and generally, some of them are of unknown significance. So meaning we don't quite understand it now, but it's in a repository that in the future, if we were to understand that, I can recontact the patient. That's number one. The other thing for a lot of folks that may not want to do genetic testing because let's say they don't have children, I still say would be very helpful for themselves, because one singular mutation can put, for example, BRCA2 actually can put somebody at risk for both colon as well as breast, and even a small risk of pancreatic. So it's very powerful to know if you have it or not have it, independent of knowing for your children. The one caveat I will tell a lot of my patients, especially if they're on the younger side, is if you're thinking about embarking on genetic testing, it is a really good idea if you've contemplated getting life insurance or disability insurance to do that first.
Yes, 100%. That's one thing that I got in residency that was drilled upon me, to get life insurance when you're younger and healthy, because heaven forbid something happens in 5 years, 10 years, you have a diagnosis that sticks with you no matter what.
Yeah.
And, my wife and I, we did genetic testing prior to the birth of our child. So yeah, if all of a sudden, again, random screening can pop something up and now it stays with you, and suddenly your life insurance plans in health insurance plans can see all that information, and suddenly you're high risk. Your premium went from $200 a month to $800 a month. Congratulations. So let's shift gears, because I want to talk a little bit about the actual process. Like, we talk about how colonoscopies are the easiest sleep you'll have. Oh, it's this and that. It's pretty simple. What somebody goes to you and says, all right, we're going to do a colonoscopy. Guide us through the process of that. What happens?
So funny, Mark. I'm not one of those GI doctors. Felt
Damn it.
when I had my colonoscopy, I felt like I went to war a little bit and then kind of came back. So it's an endeavor that definitely requires dedication. And so when somebody is thinking about having a colonoscopy, we do try to make it as easy as possible. So the first thing is if you are 45 and up and it's a screening, meaning you're not having any diarrhea, rectal bleeding, pain, etc., and kind of just doing it for age. In my practice, it's quite easy. In a lot of practices, we have something called an open access forms. At Penn Medicine Doylestown, there's just an electronic form which I created. You can put all of your demographics in there. You can even snap a picture of your insurance card. You can sign it with your finger, and then immediately it goes to my office, and then my office will call you and go through all the parameters. Generally, folks that would not qualify for open access would be if you're extremely high risk with heart disease, dialysis, on blood thinners, wearing home oxygen, that type of thing. But generally, if you're healthy, then my office would call in and discuss the procedure with you. And generally, about a week prior to the procedure, we modified the diet. So we generally ask folks to kind of eat less fiber or foods with seeds. And the reason being is that if you eat a lot of nuts and seeds, roughage can last in the colon, and then it can clog up our scopes. And then generally about a day prior to the date that you choose to schedule your colonoscopy, you will do a fast and a liquid diet. So generally, at first it sounds like, oh my gosh, I'm not going to be allowed to eat anything. Well, not quite true. I encourage a lot of liquids, so things like lemonade, apple orange juice, liquids that are clear and see-through. We do allow you to eat some solid foods that are clear. So for example, when I did my own gummy bears were my friend,
Wow.
I actually had to send my husband, my children away because, my husband would be eating fried chicken while I'm trying to fast. And so I had them go out of the house. And after a period of time, actually, I think I was just more thirsty than I was really hungry. You kind of get past that. And then generally around 5 o'clock, you'll be drinking up prep. And we have marvelous preps now. We have things ranging from that good old 4-gallon Go Lightly, which is kind of ancient, to all the way to 100% pills. So when I had my colonoscopy, I use a pill prep called Soutab. So there are 12 pills, not all together, but in the span of every 5 minutes. And there's no taste. It's very palatable. And you kind of just drink it with whichever liquid you prefer. So that could be water, Gatorade, lemonade. So really there's no taste. The only downside of this pill prep is if you have trouble swallowing, obviously wouldn't be a great agent, for you. I do allow folks to chop it in half. So, cutting the pills in half is easy. And then generally within about, 2 to 4 hours after ingesting the pills, you will have an urge to go to the bathroom. And boy, it's quick, it comes upon you. And then, after several bouts of purging, at the end, when you're kind of ready, the stools come out more like liquid. I say kind of like yelling urine. That's the toughest part. And I joke with my folks and I say, that really is a pain in the butt. Yeah, unintended. But, the nice part about it is it's a good cleanse. So, it really kind of purges out the gut, get a good night's sleep. You wake up the next morning. We do a double prep. So about 4 to 5 hours prior to the procedure, you'll do another round of the prep. And then come to my procedural unit. You meet our entire team, our nursing staff, our anesthesia team. And it really is a great nap. Generally, most colonoscopies are about half an hour to 45 minutes. And I tell folks, there can be a little bit of gas. You might want to feel like you're going to fart after the procedure, and really minimal discomfort. Most folks, feel pretty good and kind of go about their day. I take a lot of photos. I'd like to say I'm a good photo taker. And what's funner than seeing our insides, right? And most folks, I would say, tolerate very, very well. And about 4 out of 10 folks grow polyps. So again, very powerful tool because when we remove polyps, we know that prevents those polyps from growing larger into a tumor or a mass or cancer later on.
Yeah. And your agent that you use to have people go to sleep is propofol. Is that still widely used?
Yes.
Oh, propofol has a bit of an amnesic property too. So I have myself actually had an endoscopy at the age of 24, I want to say. I had some reflux, and I remember for me there was just no prep. There was just fasting the night before.
Yeah.
And they had the camera go, and I was prepped on the table. I gargled with like a lidocaine, swish and spit kind of deal. And I was always concerned about the idea of a camera going down my throat into my stomach, and I'd be gagging and discomfort and this and that. And I apparently, like, when I was on my side, they put this device in my mouth. And then the next thing I remember from one second to the other was the doctor next to me talking to me about the procedure. Literally, there was like no in between whatsoever.
Yeah.
And then the next thing I remember after that was walking out. Then I was in the car. Then I was on the couch. Like, it was a very spotty memory after that. But apparently, it's a very, very similar situation where my parents have had it multiple times now. And it's the same thing. They get a little amnesic. They don't remember what the doctor said. So one thing I say to people when they're going for procedures is try and have somebody with you. Obviously you need somebody to drive you home because you're not going to be really fit to drive. But somebody who's at least going to be able to take notes and kind of listen to the doctor after the fact, because you probably won't remember much of what happened either.
Yeah, having somebody with you is great. We always provide an extra copy of the report to take home. And generally, I do the next case or two before I come back and speak to just allow folks to really wake up and understand what's happening. But yeah, it is a great nap.
I want to tangent because you mentioned something about the prep. You said no seeds or foods with seeds or things like that. A long-standing direction for people with diverticulosis has been avoid seeds in your diet. Now, I understand that recommendation has changed a little bit, so it's not as strict, but the seed problem here is just it can obscure the camera. So it does stick around in the colon, but the thought process for those with diverticulosis, little outgoing pouches, like extra pouches in the colon, it gets stuck there and it creates diverticulitis. Is that really still a concern for that patient population?
No, that's actually completely been debunked to like 180 degrees. So, diverticulosis are the presence of these pouches. And I kind of explain it to folks that, the muscles in our body as we age sag, right? So, there's no muscle that is as taut or elastic as it was when we were 20 and 30. And so, these little sags that form within the colon, we, name it diverticulosis. 9 out of 10 folks, so 90% of folks with diverticulosis will never have a complication. But 1 out of 10, unfortunately, sometimes can have either, we don't quite understand exactly what triggers it. It can be associated with constipation or poor diet, sedentary lifestyle, obesity. But generally, something tickles these pouches, like a nut or a seed, or even a polyp, or even a tumor. And then these pouches become irritated, inflamed, and they cause a lot of pain. In the past, when somebody has had an episode of diverticulitis, we generally, for 2 weeks after the attack, we say eat a really bland, low fiber diet, which is still true. But actually, once that period pass, we recommend a high fiber diet, a fiber rich in fruits and vegetables, which do contain nuts and seeds, such as, cucumbers, tomatoes, those types of things. So the studies that came out showed that folks with diverticulosis, the pouches, when we split them in two groups, and these studies, I don't know the number off the top of my head, but like hundreds of folks with a nut seed-free diet versus a regular diet, there was no difference in
Interesting.
diverticulitis attacks. Now, being a pragmatist, I always tell folks, well, if you go out and you eat like a bag of popcorn and you have diverticulitis, well, then, maybe don't eat that bag of popcorn. But the majority of folks I see, it's generally not a direct instigator to an attack.
That's good to know, especially because I have a relative who does have diverticulosis. She was told that throughout most of her life, oh, don't eat nuts, don't eat seeds. But I noticed that the issue that most Americans specifically have is a lack of fiber in their diet. We have like a huge population that eats a lot of protein, which is great, but not a lot of fiber. Other countries getting protein is the problem. For us, is getting that fiber down. So yeah, I remember I had a general surgeon in medical school. We had a patient who was in their service for diverticulitis, and he basically was treated and he was going to be discharged. And we talked about diet for him, and he talked about fiber. And he said, yeah, you really want to pass, I quote, big fluffy poops. And it's true. Like that's the marker of a good high fiber diet in someone who I guess isn't constipated, obviously. But then the caveat to that is people who are eating, like your grains and your things with high fiber, those kind of vegetables, you got to supplement that with water too, because that can lead to constipation if you're not actually getting proper hydration, especially if you're active, but more especially if you're sedentary, because there's nothing to help propel that down out of there. So yeah, keep
Yeah.
that in mind.
Yeah. And I mean, not to belabor the point, but, my special focus is in nutrition and metabolic support. And, you have no idea how little fiber we get in America. So the American nutritional guidelines recommend 30 to 35 grams of fiber per day. And when I speak to my patients about this, a lot of folks will tell me, oh yeah, I have a bowl of salad a day, I'm good, etc. And I said, you know what? I challenge you to do a fiber count. Maybe you're right. So I started doing it for myself. A large apple, if you Google that, that's 2 grams of fiber. If you buy a traditional 5-ounce bag of spinach, let's say at Giants or the traditional grocery store, and you look on the back on the nutritional label, it's only 5 grams. Who's eating
Yeah.
6 bags of spinach a day? Even with
Yeah.
a bowl of salad for lunch and a bowl of salad for dinner, it's very hard in American diet. So I am a big proponent of recommending a fiber supplement, something like a Metamucil or Benefiber. I actually personally take one myself just to keep good gut health, because fiber has been shown to do so many wonderful things. I'll tell you this 4 things that it does that people that take it for granted. So fiber not only lubricates and traps gas within the gut, but it has been shown to decrease risk of diverticulitis. It also decreases, so a diet high in fiber will decrease polyp and cancer rate. it also naturally lowers cholesterol. So shockingly, my cardiology friends like it. I made the mistake of checking my cholesterol on January 2nd, so don't do that.
Huh,
It's
yeah.
right after
Gee, I wonder
holiday.
what happened before that. How was that?
Yeah. Yeah. And the last thing about fiber, which people don't realize, is it gives you satiety. So when you add fiber to your diet, it helps you feel full. So it's a great way of kind of like a check and balance. And a great way of thinking about it is just like oranges. So, if you drink a glass of orange juice, there's very little fiber. You're gonna, not, feel full at all. You can drink, and that could be 3 or 4 oranges to make that orange juice. Where if you take the time to peel an orange and actually eat it and ingest the fiber that comes with that, it's going to make you feel full and be more satiated with much less calories.
Yeah, I remember there's a lot of people who are into juicing, depending on, the demographic where you're living. I had known somebody in medical school that was started to get into juicing. And I asked the question, why? Why is this? So I said, well, because you can get more nutrients per serving, I guess, per, glass, whatever. And I think the problem with that mindset, because we were learning a little bit about nutrition. Yes, we do learn about nutrition in medical school for all the influencers out there. But the idea that you're not getting the fibrous portion of the vegetable, that when you juice it, you grind it down and all that pulp that you throw out, well, that's the fiber. Yes, the vitamins and the minerals are, there in your little slurry. But first of all, your body can only process a certain number of vitamins and minerals at a time, and it'll throw out the excess. So you're just kind of throwing away good vegetable matter that your gut could actually be using too. If you want a little fruit smoothie to kind of get you going through the day, fine, but also be aware that you're not getting that beneficial fiber either. So, if you're doing that stuff, supplement as you can, or just better off just eat that apple rather than juice it down or something.
I agree.
Now, as far as treatment goes with colon cancer, let's say somebody has stage 1, stage 2. What is the usual course of treatment for patients with, let's say, like, okay, they see a polyp, they see a mass, it hasn't spread anywhere yet, versus somebody now with stage 3, stage 4? Is there surgery always indicated? Is chemotherapy always indicated? What's that going to look like?
Yeah. So this is like a really big question, right? So I actually would say that I have a small cohort, probably within my 2 hands, where I've called folks up and I've said, hey, you know what? I have good news and bad news. The bad news is you have colon cancer. The good news is I took it out completely for you endoscopically with clear margins, and now you're cancer free. So that's really like what I consider to be the holy grail of GI, right? And early stage colon cancer in situ that's able to be removed endoscopically, right? So that has happened. I actually pretty much remember every single one because this is like, the dream. And in fact, I just saw somebody last week about that. And she was shocked that I remembered her. And I said, of course I remember you. So I would say while it's rare, it's, certainly possible.
Can you tell if something is cancerous based upon while you're already in there, or is it just you remove it and you find out after the fact?
So these early type of cancers, we have special lighting we can put on it that makes us suspicious, but sometimes it is very hard. I will definitely tell you this. I recently had a gentleman with Lynch syndrome, which is a genetic hereditary condition. He had about 9 colonoscopies with a partner, and I did his 10th. So with Lynch, he gets screened very frequently. The guideline is 1 to 2 years, and it was a small polyp. I was shocked, actually, that it came back as colon cancer.
Wow.
He was cured, and actually, I just did his 3-year follow-up surveillance colonoscopy, within the past 2 weeks or so, and he remains cured. And now I actually take care of his daughter, who also has Lynch. He has 3 children, only one of whom is positive. So those cases definitely stay with you because they're really the strong wins.
Yeah.
Now, the other types, the stage 2 that is not resectable endoscopically or, stage 1, then I would say generally I would refer them to one of my amazing colorectal surgeon partners. We're fortunate that I work with 3. And then depending on the location, so generally I would tattoo it to help with the surgical, planning. We generally stage with CAT scan. So a CAT scan of the chest, abdomen, pelvis. We check tumor markers, blood work. And these folks generally are resectable. And with a colonic resection, surgically, the lymph nodes will be checked to assure the proper staging. And then generally these patients are cured. They do undergo surveillance colonoscopies a year after their, resection. And then generally if that's healthy, then goes to 3 and then 5 years. Now, the tough stages are the stage 3, kind of a stage 3 really requires a multidisciplinary approach. It also really depends where. So colon cancer encompasses the rectum, but the rectal cancers are treated a little bit differently. So rectal cancers tend to get chemotherapy and radiation up front to shrink them, and then consideration of surgery afterwards. Whereas most areas in the colon in earlier stages can be operated upon first. What is devastating, unfortunately, is the stage 4 colon cancers. And I will tell you, if there is spread to the liver, the bones, other areas within the body, then generally it's not curable, but it's treatable with chemotherapy, radiation. Sometimes can be offered surgery to treat symptoms, if somebody is very obstructed or bleeding is predominant symptom. But that's kind of, the wide array of where colon cancer can be found. But really, with good screening guidelines, we really should be catching colon cancer early and curing a lot of folks. Yeah, so that's really important.
What is the prognosis in terms of years, months, even about for a stage 4 diagnosis on average, would you say?
I think for me, it is very, very hard to say that to someone. So I think it's a variety of factors. I think that the patient's comorbidities, meaning, is this a young person that really otherwise doesn't take medication, is healthy, versus somebody that may be older with other health issues like heart failure, dialysis, emphysemas. So I think how someone does respond to treatment is highly variable based on their based on their baseline health prior to the diagnosis.
Yeah, I think ultimately, end of the day, the message is, screening saves lives. We need to have people be aware that, colon cancer is not just a treatable and, curable cancer, but one that doesn't have to begin in the first place. That, that's the main thing. And it's so easy to screen for it and then treat it while it's early, that it should not be a fight. But people are scared of the procedure. They're scared of the diagnosis that comes with it. So I get it. All of us understand no one wants to diagnose this. No one wants to go through a procedure that sounds horrible, but it's not. That's the thing. It's not. People say it's the best app you'll have for a very good reason, I think.
Yeah. And I think that also nowadays, primary care physicians also are offering the stool-based testing, like, that are picking up microscopic blood and or the Cologuard, which picks up, methylated DNA of some of the tumors. But what I tell a lot of folks is, in life, the effort really correlates to the benefit, right? So while the stool studies are very easy to do, I don't, disparage anybody from doing it because something is better than nothing. But the stool studies are really there to detect cancer, right? When a Cologuard turns positive, it's detecting potentially some methylated DNA. It's not preventative. A colonoscopy truly is the ultimate test because not only can it detect cancer, but like I mentioned, it can prevent it by taking out polyps at a small stage or even remove early stage cancer and cure cancer right there. So a colonoscopy is the only screening modality that allows detection and prevention. And that really is a big distinction.
Yeah, one of the things we do in the ER, and I'll relate it to this, is called a D dimer. So a D dimer is a test we do often in the ER for a screening for pulmonary embolism. So if somebody comes in, they're 27 years old, they have chest pain. The odds of you having a heart attack are low just based upon your age alone, unless there's other factors at play. But for other demographics and women, especially say who are on birth control or there's some kind of a clotting disorder, they could be at risk for blood clots in the lung. And I tell my residents, say, if you did a D dimer, like if you sent this person home without any testing, you didn't consider it, would you sleep at night? Probably not. So you do a D dimer, you screen for it. If it's positive, doesn't mean you got it. It just means now we got to do, a CAT scan of the chest. But now let's say somebody comes in, they're 65 years old, they've been coughing up blood, they're having really bad chest pain. Yeah, they're not having a heart attack. What are the odds of them having a possible blood clot in the lung? Higher, right? So I say to them, would you sleep well at night if you did a D dimer on this patient and it came back negative? You say, hey, your D dimer is negative, go home. It's probably not a blood clot in the lung. You probably wouldn't, right? Because the risk is, we talk about false positive, false negative, all these different testing terms. At the end of the day, a Cologuard, I think, in my opinion, is great for somebody who's young, with no risk factors who may not be eligible to get a screening colonoscopy yet. Are they concerned about it? Is there something going on? They're a little bit more constipated than usual. Sure, get it. I would first of all advise talking to your doctor of all things. But sure, if you want to, at least kind of you're curious about it, if you're concerned, get the Cologuard, try and see what happens. If you're 65 years old, I'm sorry, but Cologuard, if it's negative, ain't doing it. Okay, you got to get that colonoscopy here. I can see a situation where insurance is probably going to be like, yeah, if you're 30 years old, you want screening, here's a Cologuard, we'll approve that, we won't approve a colonoscopy. I understand that logic. They're barring, other risk factors and things like that. But yeah, the Cologuard testing is good for some people. Once you hit the age where colonoscopies become a routine thing, it's not. You got to stop. All right. Well, Dr. Hannah Doe, thank you again for joining me. GI physician, fellow colleague of mine up at Doylestown Health, part of now Penn Medicine. If you're in the area, in the Bucks County area, definitely call her up, schedule your next colonoscopy, especially if you're 45 and older. Okay. So it is the best sleep you'll ever have, as they say.
Yeah, for sure. And thank you so much, Mark, for having me on the show. I very much appreciate it. And like I mentioned, if anybody's interested in talking about screening or any other GI digestive issues, feel free to call my office. And then I'm also happy to share my open access form link with Mark as well.
Yeah, I'll put that in the description on YouTube and as well as the podcast sites as well. So if you're listening to this in your car, like my wife may or may not be, by all means, go into the website, take a look at the link if you're in the area. Obviously, if you're living in California, probably a little bit difficult unless you want to fly out all the way over here. But either way, so hey, Dr. Doe, thank you for coming on. I'll see you next time, I'm sure. We have a lot more to discuss about other topics as well.
Yep, it's my pleasure. Take care and have a great rest of your day. See you, everybody.
All right. Thanks again to Dr. Hannah Doe for joining me here on the JAFERD cast, gastroenterologist affiliated with Penn Medicine at Doylestown Health. Some key items to hammer home before you head out. 45 is the new 50. If you're 45 years old, you're eligible for a colonoscopy. No excuses. It's not just gallons of sludge as far as the prep goes anymore either. Pill preps are a game changer, and preps overall are less taxing compared to previous. Also, don't forget to increase your fiber intake, as chances are you're probably not getting enough. And remember, stool tests find cancer, but colonoscopies prevent it. Choose wisely. As usual, though, don't take our advice on it. If you have any questions or concerns about your health, reach out and talk to your own doctor. If you found this helpful, or at least mildly entertaining, do the thing. Hit subscribe, leave a 5-star review on Apple or Spotify, and check the description for Dr. Doe's open access link if you're in the Philly, Bucks County area. Stay safe, keep those pipes clean, and I'll see you next time.